Today on Primary Care, migraine headaches, a debilitating disease that each year affects more than 36 million men, women, and children.
They said that I had complex migraines, only I didn't know what complex migraines were.
Hello, I'm Dr. Lonnie Joe and welcome to Primary Care. Did you know that migraine and headache are leading causes of outpatient and emergency room visits? According to the American Headache Society, the prevalence of migraine headache is high, affecting roughly 1 out of every 7 Americans annually. Although migraines are an important public health problem, there is remarkably little research on race differences in persons with headache disorders. Dr. Larry Charleston joins me today to share information on migraine headaches. Dr. Charleston is a headache neurologist and an associate professor of neurology at the University of Michigan Medical School. He is also a fellow of the American Headache Society. Dr. Charleston, welcome to the show.
Thank you so
Good
much.
to see you.
For being here. Excellent. To be here.
Good.
This is wonderful.
Excellent. Thank you. It's such a pleasure. We go back a ways.
Yes, we go back a ways, and in my training, and it's just wonderful to have this opportunity to sit and share, and I thank you for a lot of things that you've done for me, actually.
Larry, we're proud to have you. You know, everybody in this society has had a headache. Some people say you're my headache or that the job's my headache, but everybody in this society has suffered from a headache at one time or another. A lot of people will call them migraine headaches. Do we really have a definition for what a migraine headache is?
So we have a classification of migraine headache, and when we talk about headache, and this is one thing I did not know until later in my training, that there are 300 different headache diagnoses, okay?
300?
300, maybe a little bit more, but right around 300 different headache diagnoses. And migraine itself is the second most disabling neurological disorder. Like, a lot of people don't know that, right? The most common neurological disorder is stroke. But this is second to stroke is migraine.
Not just headache in general, but migraine headache specifically, second most.
Yes, and when I say migraine, I think of migraine as a syndrome, okay? Because there are different phases to the syndrome, and the headache part, the headache attack is just the attack phase, the head pain phase of the migraine syndrome. So migraine usually occurs on one side, or about 60% of the time occurs on one side of the head. It's associated with photophobia or sensitivity to light, sounds, and sometimes smells, nausea, and vomiting. And it is a primary headache disorder, meaning that there's no secondary cause for that. It occurs in probably about anywhere, estimates go from 36 to 38 million Americans. And there's a spectrum. There's some people that get them once, every year, and then there's some people that have them all day, every day. And so there is a spectrum from migraine and chronic migraine.
Is there an age group or a particular group of individuals that have a predilection to suffer from migraine?
Yes, I work with adults, but the pediatric population is about the same 1-to-1. But as people get into their adulthood, it's about 2 to 3 to 1 women to men. And it usually occurs in a lot of women in their reproductive years of their life. And so, yes, it does. I mean, it's about 18% in women in the United States, about 18% of women. So that's almost 1 out of every 5 women have some type of migraine disorder, and it occurs in about 6% of men.
So women suffer from migraines more than anyone else in the population?
We do think that there may be some hormonal factors, some contributors and things like that, but we don't really know exactly why is that. I mean, estrogen component does play a role.
Does a migraine headache damage the brain? Any structural damage to the brain?
So no, what we may find that there are, in some patients with migraine with aura and migraine without aura. So let me define that first, okay? Migraine with aura, you have to have at least 2 attacks where you have reversible neurological signs that occur with the headache. Most common is visual aura. where people may see a lot of spots. The peripheral vision might be obscure. There may be zigzag lines and things like that. The migraine without aura obviously does not have that, but some people can also have sensory aura as well. So the auras occur, they usually happen from 5 to 60 minutes is kind of what the definition is. And it tends to be stereotypic in a particular patient, but only 1/4, so 20 to 30% of patients have migraine with aura. So with migraine with aura, we have to be really, really careful, because even when we start thinking about risk of stroke, about stroke-related migraine, and that's with anybody who has stroke with migraine or what have you. It's about 3 in 200,000 people that would have that, and most of the association has been in the patients with migraine with aura. So going back to the brain question, is there anything happening in the brain? There's something happening in the brain. We don't know it to be destructive. For instance, there's some studies that show that you may have imaging, in brain imaging, you may have what we call white matter lesions. So we know something is going on, but there's no evidence right now that anything bad is going on.
Are these lesions seen more on MRI versus CT scans?
Yes, so the imaging of choice in most headache disorders, not all, most headache disorders would be an MRI. And it's usually seen actually in the posterior circulation, where we will see these white matter lesions. But if we see anything else, and if someone has a headache, it might be a headache secondary to whatever we see. So, but these are similar things that we can find in cardiovascular disease. We can see this in diabetes, sometimes these type of white matter lesions. But there is in the posterior circulation of the brain, we might see some of these white matter lesions, but we don't know exactly what they represent and if they're actually bad for the patient.
Larry, we have to go to a break, but coming up, meet a woman whose migraines were misdiagnosed for most of her adult life.
We women sure know a lot of numbers by heart. But do you know the most critical numbers for your heart health? That knowledge could save your life. Do you know your numbers? Talk to your healthcare provider today to learn your health numbers. Your heart depends on it.
Ever heard of a migraine that mimics epilepsy and symptoms of a stroke? Well, neither did Sandra Robinson, a retired school administrator who, after 30 years of being misdiagnosed, was finally given the correct diagnosis for her rare condition.
My name is Sandra Robinson. I'm a retired school administrator. I'm also a minister, and I have hemiplegic migraines. They're called hemiplegic migraines because they mimic stroke-like symptoms. I will have slurred speech. My face will become twisted. It's usually the left side of my body will become weak. At times, I cannot walk. I cannot move the left side of my body at all. Someone will have to help me move. I lose concentration. I know what I want to say, but I'm unable to say it. I have a sensitivity to light. I have a sensitivity to sound. Sometimes when I'm places, I have to use earplugs. I actually started experiencing these migraines back in college, and it just started evolving over time. They became worse and worse over time. Through the years, I have been misdiagnosed that they have said that I've had epilepsy. They have misdiagnosed me as having TIAs. They have misdiagnosed me just simply telling me that is my imagination. I recall on more than one occasion ended up in the emergency room and the doctor looking at me and saying, "Sandra, quit doing this to your family. Stop doing this to your friends. You know that there's nothing wrong with you." And that just hurt, and it just excuse colloquialism, just cut to the core, because I'm laying there and I'm thinking, I'm not doing this to myself. Why would I make myself sick? If I could make my face not be twisted, I could make my speech be normal, if I could get up off this bed, I would. Why would I do these things? And they sent me to University of Michigan. And University of Michigan ruled out epilepsy, and they said that I had complex migraines. Only I didn't know what complex migraines were, and they took me off of all of my epilepsy medication. And I ended up feeling better, but I would have migraines through the years still, but not as severe. And one of the nurses at my church, they're such a blessing. I'm blessed to work around nurses and doctors at church. And she said, next time you have an episode, they suggested the nurses, because they had seen me have these episodes through the years. They said, we need you to start videotaping this. So we took out the phone on our camera, the camera on our phone, and we taped it. And so when I met with the neurologist at University of Michigan, we showed him the videotape of the episode. And he said, I'm pretty sure that's a hemiplegic migraine. To know and have a diagnosis is much better than not knowing. Even though people still don't understand that a migraine is more than a headache, and people still want to call it other things and still look at me and don't understand what's going on, that's okay. At least I understand and know, and to have more information makes a difference. So I'm more aware of triggers, what to watch out, what to eat, what to avoid, what to be conscious of. It makes a difference. It gives me more control over my environment and more control over my life. And I can look back now and understand that there were times that I put myself in situations that made me more vulnerable to having a migraine, and I didn't even realize it.
Dr. Charleston, Ms. Robinson is a patient of yours who had a long history of suffering with headaches all the way back to college, misdiagnosed. Why does it take so long for some patients to get an accurate diagnosis of migraine headaches?
I really wish I knew that. I know that it is important to understand what migraine is, okay, and what it can be, and the variants of migraine. It's also probably the most essential thing when seeing a patient is actually taking a history. And we have to think of this as a neurological disorder. Like this, we can't just dismiss it, oh, this is just something that is in someone's head, pun intended. But no, we can't, but we can't just say that this is, or they're just making this up or whatever. We really have to listen to the patient. It's very interesting. I have a headache intake form that's several pages. People call it the book. But we know that it's really, really important that I understand those things with the book, because that's going to give me some things that you may not, if you were a patient coming to me, some things you may not even thought about that occur with your headache that's going to really help with the diagnosis. So it does take time, and it does take understanding and knowing the different diagnoses that we have.
So the questionnaire draws out other information that would not necessarily be addressed during the course of a normal interview.
Right, and so sometimes patients don't necessarily think about it. So they may say that I want you to believe that I have this headache that is severe, and I didn't mention that when I was talking about the diagnosis, that is a moderate to severe headache, usually lasting 4 to 72 hours if it's untreated or unsuccessfully treated. And so they really a lot of times patients want you to understand that, hey, I have a headache, please believe me, this is not all in my head. But so they may not tell me that, oh, when I put my glasses on, it hurts my head, or I can't put my hair in a bun, or when I brush my hair, it hurts. Well, that's going to be critical information, not only just to know, but as far as your plan is concerned, because that's what's called allodynia, right? And that's a sensitive areas of touch and non-painful stimuli that feels to be painful. And that's important. That's important when it comes to treatment options. So yeah, so there are different things that we try to pull out. And actually patients, sometimes they say, because not a lot of people like to do the forms. I get that. I don't like doing forms either, right? But it's just so important so that we individualize the care to that patient. And there are things that they may not have thought about.
Mm-hmm. It's a tailored plan for those patients. Maybe Ms. Robinson would have been diagnosed earlier, treated differently if that approach had taken place. But in her case, tell us what a hemiplegic migraine is.
So hemiplegic migraine, I'll try to break it down to the essence of it. So hemi, half, plegic, weakness, right? Migraine. So you have episodes of periodic weakness that usually affects one side that occurs with the migraine attack, okay? We think this might be part of the aura, so it's like a motor aura. See, I talked about visual and peripheral and sensory, like numbness and tingling and things like that. But another neurological symptom is weakness. So when you have the motor component, that's when we're thinking hemiplegic migraine. The causes of hemiplegic migraine, there's some genetic, we think that there may be some genetic causes, but there's also what we call sporadic. So it just happens. There is one other diagnosis too that I actually did consider, and this one is not actually in the classification, but it's been reported, which is called migraine with unilateral motor symptoms, which is MUMS. And they have a little bit of a different history to it. People with hemiplegic migraine tend to have theirs, particularly if it's familial hemiplegic migraine, they typically have theirs earlier in life. So we have to really think outside the box when something has happened. Now, when someone comes with motor symptoms or weakness, I get it the first time you're looking for stroke, okay? We really want to rule stroke out. We want to rule out a transient ischemic attack. We understand that. In fact, there are several things that are kind of red flags when it comes to headache disorders anyway. So if it is very sudden, like a thunderclap headache, if it's new, it's a new type of phenomena, or if they have other neurological deficits, which Ms. Robinson did, right? If the onset is after age 50, if there's a postural component to it, if it occurs during exercise or even during sex or coughing and things like that. And sometimes we may want to look at things for pregnancy. If there's a really severe headache in pregnancy, that's different. So we really want to look at that. But also, if there's other systemic diseases or anything else going on, if there's fevers, chills, and everything with this headache or headache attack, we really want to look into that. And neck stiffness, of course, we want to look into that.
Right, Larry, we need to talk about treatment, but before we do that, we have to take a break. We'll be right back with more of Primary Care when we return.
When we adopt a shelter pet, we discover they're a unique mix of all kinds of things.
There it is. Keep going with it. Leo!
They're a little bit of a lot of things, but they're all pure love.
First time I tried Vicodin, it was laying around my mom's house. I didn't know they'd be this addictive. I didn't know how far I'd go to get more.
Opioid dependence can happen after just 5 days. Know the truth, spread the truth.
This is what high blood pressure looks like. Talk with your doctor to create a treatment plan that works for you. Go to loweryourhbp.org.
Welcome back. We're here with Dr. Larry Charleston, neurologist and associate professor of neurology at the University of Michigan Medical School. Let's talk more about the treatment of this very prevalent disease called migraine headaches. What is the latest and the greatest at this point?
Well, before we get to the latest and greatest, I like to say what I call a comprehensive treatment plan first. And because the latest and the greatest usually fits within components of that comprehensive treatment plan.
And specific for each patient.
Yeah, it is absolutely. And so I'd say there's 3 elements to a treatment plan. And one is the abortive or the acute pain medications, something you take to abort or get rid of the headache. Those we have to be very, very careful with because usually abortive should not be used more than 2 days per week. And in fact, if patients are using anti-pain medications more than 2 days per week, that might be a reason to see a provider. The other part of the plan is prevention or prophylaxis. And the goals of prevention are to decrease the number of days with headache, decrease the severity of the headache, decrease the duration of the headache, help the abortive medications work better or help you to be able to take less abortive medications, and or help improve quality of life. And now notice I said and or. So we want to try to get as many as we can, but if that preventive is doing one of those, then the preventive is doing its job. Now, one thing about preventive is that when these medications or natural supplements or whatever it is was studied, it was usually studied at 12 to 16 weeks. So it lets us know that it takes time for it. And that's one of the things we have to kind of educate people about it because I get it, we want it right now, but it takes time with these preventives. And then the third part of a treatment plan is non-pharmacological. Non-pharmacological or modalities, I also say headache healthiness or behavioral modalities. Like for an example, the one that's been most studied and clinically proven to be effective are actually two, is biofeedback and cognitive behavior therapy. Those modalities have very high evidence in helping patients with headache disorders, but things that we can do on a daily basis. Hydration. Dehydration is #1 trigger of headaches across the world. So we definitely want to make sure we're hydrating. We want to hydrate with water. If we do juice, because you get like this when you get juice, because there's some hidden calories in there. I'm kind of a juice head, but that's okay. So, but you just have to be careful with that. Deep breathing exercises, progressive relaxation, guided imagery, knowing what your triggers are. If you can identify triggers, trigger avoidance, but we can't always avoid triggers. So sometimes there's trigger coping. So within those, and there's other things, but within those three elements, I say that's more of a comprehensive plan. So latest and greatest, recently, there have been what we call the CGRP modulators. So CGRP stands for calcitonin gene-related peptide modulators. And now what's important about that is that we think that this has a significant role within the pathophysiology of migraine. And so here recently there's been the monoclonal antibodies to either the CGRP receptor or actually to the actual protein or the ligand itself. And what's really interesting about that is that those were designed specifically for migraine. A lot of our treatments, we borrow treatments from different classes of medications, but that was designed specifically for migraine, and they're the first biological medications that for the treatment of migraine.
Larry, are you seeing any differences between ethnicity in terms of the onset, the severity, the treatment response in migraine headaches? In other words, are African Americans disproportionately affected by this disease state?
So the severity in African Americans is one of the characteristics that we see that's elevated, and that there is a disparity. And we don't know why. I mean, and that leads really to one of the biggest disparities that I see is actually participation of minorities in clinical trials. Here recently, the NIH has started to require reporting with minorities as part of, in your grant application and everything. Right. To do that. I think that's a big deal. There are a lot of similarities, but there are also some differences. And so when I try to extrapolate one treatment that hasn't necessarily been in this population, or there weren't a lot of people that were studied in this population, I mean, it's really hard to really tell people. I mean, it's the generalizability of that within African Americans, we don't know. And so So I want my patients to have, whatever their ethnic background, I want them to have the best care, and like we said before, individualizing the care to them, and it's really hard to do. And so minority participation in studies is one big thing that's lacking. And then African Americans, with the severity, I mean, they may have more chronic, we do need more studies.
So like in other disease states, education, information, access to care, treatment, we revisit those areas in almost everything that we talk about in healthcare nowadays. But suffice it to say, it looks like we're in good hands in the treatment of migraine headache. Dr. Charleston, it's been a pleasure having you on the show today, helping us understand all of the details about migraine headaches. We'll do this again. Thank you so much.
Thank you so much for having me and everything that you do for the community.
Thank you. We've been talking with Dr. Larry Charleston from the Neurology Department at the University of Michigan Medical School here on Primary Care. Stay with us. We'll be right back for some final thoughts.
All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become 1 in a million.
Here's some final thoughts. Migraine headache. People who suffer from headaches should seek treatment to identify what type of headache it is and what modalities are available for treatment. You'll be surprised at the progress that has been made in treating migraines, and the conditions of these patients who continue to suffer can be improved greatly. For Primary Care, I'm Dr. Lonnie Joe.